So this presentation is looking at educating the chronic pain patient in the outpatient pain management setting. In our particular clinic, we deal a lot with chronic pain, and this presentation hopes to shed some light on the issues that the patient is facing and how we can help them. So for proper research, you need to have a proper research question. So we're looking at, does patient education about neurologic pain combined with physical therapy treatments improve stated subjective outcomes compared to treatment-based therapy only in chronic pain patients? Pain is a subjective measure and therefore constitute a difficult outcome to modify. Each day we ask the same questions of each patient that comes through. How is your pain today? Every person's pain perception is going to be different. We have those that come in stating a 10 out of 10 and are laughing while talking on the phone. And then we have those stating a 3 out of 10 and who can barely crawl in through the door. So can knowledge of pain and the physiological process help patients with their daily lives? So what is pain? Pain is something that is felt in the body, alerting us that something is wrong. It can be either acute, immediate, or chronic, having been there for a long time. Most medical professionals acknowledge that chronic pain is pain that lasts longer than 3 months. The International Association for the Study of Pain and the World Health Organization define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such pain. It's estimated that 20% of adults globally deal with pain, and that 10% new cases of chronic pain are diagnosed each year. With a world population of 7.6 billion estimated, that's roughly 760 million people suffering with newly diagnosed chronic pain each year. So we won't be running out of patients anytime soon. So the pain starts in the peripheral nervous system. That's our arms and legs and our core that has pain receptors throughout it called nociceptors. They respond to tissue damage and send an electrical signal to the brain through the spinal cord. There's a couple different types of fibers that send the pain. There's a fast and a slow. The A delta fibers are fast and move at about 40 miles an hour. The C fibers are slower and move at about 3 miles an hour. What's interesting is that when we hurt our arm, let's say we bump our elbow, we start feeling that first pain, and then we sit there and we rub it with our hand and it seems like the pain goes down. That's actually because they found other fibers that are faster than A delta fibers. They can override the signal and basically mute it to where the brain doesn't receive such a strong sensation from it. We apply that in the clinic by different types of distractions such as massage, hot and cold packs, and TENS units. So now the signal goes from the periphery through the spinal cord up into the brain. So with acute pain, the brain receives the signal in the cerebral cortex, which is what's considered our higher thinking, and it's going to give a quick action response as far as getting away from the cause of the irritation and getting away from the threat. But for chronic pain, the signal actually goes to the hypothalamus and limbic system. The hypothalamus is responsible for the release of certain stress hormones in the body, while the limbic system is responsible for processing emotions. This is one reason why chronic pain is often associated with stress, depression, and anxiety. The slow pain signals are actually passing through the brain areas that control experiences and emotions, and they're recoding them. Many factors that will determine how the spine nerve gates will manage the pain signal. These factors include the intensity of the pain message, competition from other incoming nerves, and signals from the brain telling the cord to either increase or decrease the priority of the pain signal. And depending on how the gates process the signal, the message can be handled in any of the following ways. It can be allowed to pass to the brain directly. It can be altered before reaching the brain, such as the expectations or the emotions that have been coded to it. or actually prevent it from reaching the brain. Interestingly enough is that our brain doesn't have any pain receptors, so it doesn't feel pain, but it sure is good at making receptors for the rest of the body. So what exactly is chronic pain? Chronic pain is a signal that's being continually sent to the brain that there's an injury or that there's possible tissue damage happening. And what has occurred is that the brain has not realized that it is a non-threat after all the time that the signal keeps getting passed through. Dr. William Deardorff gives the example of a clothespin on the skin. You clamp it on and at first it hurts, but after a while it starts going numb and you don't realize that it's there anymore because the brain has realized that it's not a threat, that there's no tissue damage happening, and that it can start to ignore it. Same happens with a tight-fitting shoe. But with chronic pain is that we start worrying about what could be attached to the pain because we may not know what's going on inside of the back. So we give an emotional stamp to the pain signal and the brain will not forget about it. With the continued added emotion, the signal maintains strength and therefore it is always felt. It's just this constant loop. The signal needs to be recoded with a better meaning or understanding of why it's being sent. Quick review of a couple theories of pain that are out there. The original was the specificity theory, started back in the 16th century, and it was thought that the amount of pain was directly correlated to how much tissue loss had happened or how much had been damaged. This was actually debunked by a Dr. Henry Beecher working during World War II, and he found when he got back home that civilians had a significant more stated pain than those who had actually received more tissue damage out on the battlefield. He theorized that the soldiers felt less pain because they were thankful to be alive, while the civilians were worried on how the injury would impact their lives. In short, it came down to how the brain was interpreting the pain signals. So the other theory, the more common accepted theory, is the gate control. This was theorized by Ronald Melzek and Patrick Wall in the 60s. It's theorized that sensory, cognitive, and emotional factors can either make the pain worse or better, depending on the thinking and choices of the person. Inactivity, narcotics, and poor body mechanics can affect the sensory. Focusing on the pain, worrying, and no outside distractions can affect the cognition. And depression, anger, anxiety, stress, frustration, hopelessness, helplessness will emotionally affect those signals. But on the other hand, the sensory factors can have a positive influence by increasing activities, short-term use of pain medications, relaxation training, and meditation. The cognitive factors could be improved with outside interests and distracting oneself from the constant pain. And emotional factors such as having a positive attitude, overcoming depression, feeling reassured that the pain is not actually causing harm, and taking control of one's chronic pain in life would bring about a better stress management and help the signals. But the question is, will it actually work in real life? So the first study we looked at actually had to deal with acute pain, but it actually was fitting for our topic of discussion. There was two groups, both of them received exercise, and the study group also received education on pain management. The education they were giving was from the physical therapist as well as a book called Back Pain: How to Control a Nagging Backache. The participants had all returned to work within 45 days in the education group, while a third of the control group subjects still had not returned by 45 days, and 3 still had not returned by 90 days. Their conclusion was that education with PT interventions was effective at returning acute low back injury patients to work quicker than just physical therapy alone. This next study was focusing on chronic pain in whiplash patients. They did not have a control group. They just applied education through pamphlets and one-on-one education to 6 patients. And all scales showed an improvement. And since they did not have any other intervention, it was assumed that the education was what caused the improvement in the pain scales. This next study was quite beneficial for my particular setting, as we are an aquatic therapy clinic. It did use 2 groups. The study group received aquatic therapy along with education, and the control group received just the aquatic therapy. At the 3-month follow-up, the study group reported a 72% perceived benefit in functional disability compared to the control group. It's pretty significant. The study's findings supported the application of pain neurophysiology education as a clinically effective addition to aquatic therapy. So this next study was a little different. They had 2 groups, but they were actually trying to find out if education alone would be comparable to physical therapy training for chronic low back pain. And what they did was that there were 6 sessions of exercise for the exercise group and 3 sessions of just education while encouraging inactivity in the study group. And what their conclusion was that education based resulted in at least as good as exercise alone intervention, showing that standalone exercises for treatment of chronic low back pain should be reconsidered. Last article didn't actually use a study group. It was actually just looking at the recent findings of actual structural changes in the central nervous system in those with chronic low back pain. Research used by the authors showed an actual decrease in the gray matter in those with chronic pain, but they did state that further research needed to be performed. What they stated was that when the brain has been molded due to chronic pain, it actually created new motor training that restricted certain motions, specifically in the lumbar spine. And those that had chronic pain showed different areas in the brain responding to pain, and in areas that normally are not involved with pain in CT scans. What was interesting was that the study stressed that to reprogram the brain and the motor skills is that it should not be based on a pain report from the patient, but that it needed to be time dependent for exercise changing. So how does all this apply in the pain management clinic? I feel the literature has shown that by applying neurophysiology education in conjunction with therapeutic interventions, there's going to be better patient outcome. All the research discussed shows that education or interventions alone is insufficient to bring about the results that combining the 2 can. Now, for application in the clinic, it is imperative that those who are going to do it with the patient actually understand it completely. Most of the research did state that a misunderstanding of what was going on in the body of the patient was one of the big causers of the stress that they had within their mind, which of course is putting that stamp on the brain signal. So if the patient has limited understanding of the body or may not be able to understand a basic explanation from the PT, it's almost best left unsaid. So here can be one of your everyday clinic examples. Patient arrives to the pain management physical therapy clinic stating that he has had years and years of chronic back pain. When interventions are attempted to be applied, he states that he is afraid of the pain that comes from exercising, as he has tried to do it before in the past. The physical therapist can take the time to sit down and explain the neurophysiology of the body and how different applications of his thought, his daily activity, and the events that he goes through each day can actually start changing his outlook on the pain that he has, and hopefully start getting some of that neuro re-education and reprogramming of the pain signals. Hopefully the patient will apply these things, and by the research that we've shown, will start having better stated outcomes and better pain tolerance with everyday living activities. Such as with the example shown, what will come about through this scenario is that Mr. Smith will understand his condition, and that he may always have pain, but that is not necessarily damaging anything, and that he doesn't need to stress about it. Of most important is just applying stress relief factors through meditation, fun activities, and of course physical activity. The research provided has demonstrated that an addition of pain neurophysiology in the treatment of chronic pain can have an improvement on the stated outcome of patients. It takes relatively minimal time to give this education to the patients, especially when using handouts, but can produce significant results. So can we say that patient education about neurologic pain combined with physical therapy treatments improves stated subjective outcomes compared to treatment-based therapy only in chronic pain patients? We certainly can. Thank you for your time.